Neurologic trauma, chapter 68. So head injury. Majority of the people who get head injuries is men, boys, young boys in young adult teenage years, or unfortunately the elderly with falls. It's usually falls. There's also, obviously the car accidents, blunt traumas. In one of the lectures I said I had a friend who was hit over the head with a bat. He was robbed. Freak accidents like that, but majority of them are the adolescent age and older adults. So here's the rest of your statistics here. Prevention's best. So just a lot of health promotion, safety, reckless behavior, the problem there. We see many times where young teenage boys will jump off the roof into a shallow pool and there's a massive head injury right there. Things like that. So here's the patho of brain damage. Remember, the brain is not forgiving. Okay. Contusions, lacerations. Yes, these are external issues, hematomas, but remember, the brain is not forgiving. There's no room for it to swell. So these minor issues here can become severe. We don't know what's going on inside. So some close monitoring after a injury. Concussions. Concussions are unfortunately very common. Obviously, we have CTD out there. The more frequent the concussion, the more permanent damage. Every time somebody acquires a concussion, the healing process of this is not the same. There's always some kind of damage, even if it's minor, every single time. Okay, there's always an issue. So understand the difference between primary and secondary injury. Primary, consequence of direct contact of head during instant initial. Secondary, it's the damage afterwards, as I was stating. So just make sure you understand the difference. Here's your patho right here. So scalp wound and fractures, they tend to bleed heavily. It's kind of vasculature, can be localized pain. Skull fractures, obviously we need some close monitoring to make sure there's no CSF leaking from the brain. So it depends on the type of skull fracture. Sometimes they can be possibly sent home if they think it's just superficial. If they're older, live rural, if they live alone, sometimes we will keep them overnight to make sure this isn't anything more severe, but we will send them home with this education, making sure that they understand. We are monitoring for CSF leaking. How would that look like? Just clear fluid out of the nose or out of the ears. Okay. We would also see bruising in certain areas behind the ears right here. Okay. It can be hard to kind of tell sometimes, but think about it. It's kind of an odd place for a bruise. So this is called battle sign. CSF leaking. We can put it on a small gauze usually, have a little bit and drip it there. When it starts to separate from the blood, it's called a halo sign. It's because of the sugar that was left in it. Excuse me, not sugar, glucose. So CSF is full of glucose, not sugar. And when it sits down with the blood, it automatically separates, and that creates that clear halo sign. Let me see. So here would be a fracture in the area here. So the way these are worded, any kind of skull fracture, is the location. Okay, so just be familiar and understand the terminology. So if you have a question, you understand where the injury is. Okay, so management of patient. Of course, this is constant monitoring of a level of altered level of conscious, alert and oriented, if they're able to obey commands, pupils. A whole neuro assessment is imperative if there's any kind of possible head injury. Okay, so management of head injury. So you always want to assume the spine could be involved. So what does that mean? We don't necessarily want to be moving the patient around. We want to keep them straight and aligned as much as we can. Treat cerebral edema. Maintain cerebral perfusion, treat that hypotension, hypovolemia if there's bleeding from the area, and make sure to monitor any ICP. Maintain oxygenation, cardiovascular, so every piece of perfusion. And making sure, are they able to maintain it on their own? Are we losing that autonomic regulation? Manage fluids and electrolyte balance. So supportive measures, again, respiratory. If we're having issues, neurally, we want to make sure we have an airway. Okay, this would be obviously for a more invasive neuro injury. A minor injury probably won't need it, but again, understand that's one of the biggest areas we are looking at. Seizure precautions, preventions, let's get those pads out. NG tube to prevent that aspiration, manage gastric motility. Remember, we want to keep that acidity down. Fluid and electrolyte maintenance, pain and anxiety, and nutrition. Remember, nutrition is right away not the priority, but we're talking about 4 or 5 days in, we're going to really need to be paying attention to nutrition. Remember, we are taking care of the whole body. We are not sure what kind of injury they have. We are going to have to maintain range of motion, you know, high protein, good carbs, reducing that gastric motility, skin integrity, keeping them aligned, not giving any kind of false hope to family, really assessing for pain, nonverbal cues, family, fear. Okay, so brain injury, alter level of conscious. Again, go down the list for a neuro assessment. Pupillary abnormalities, one is bigger than the other. They don't contract. Sudden onset of neurodeficit change. Again, it could be onset. The older a patient is, this could be a gradual occurrence. One of the biggest reasons why we ask, have you fallen in the last 6 months? Elderly will have a tiny slow bleed. They'll have a trip or a fall. They went in, but within the next 3 or 4 months, they could be slowly bleeding. It could be a gradual thing. Then all of a sudden, we've had family members come and say, you know, I went to check on my mom. She was kind of having problems with her gait. She wasn't making sense when she talked. She was mumbling, but it was very subtle. Again, it's never okay to be confused. And if family members can be educated and understand that, they'll bring their loved ones in sooner for check. Okay? Changes of senses, movement, reflexes. That family member I was telling you about, she kept saying she was trying to get up just one step, and that wasn't like her. She's very independent. Changes in vital signs. Remember, what are we possibly looking for? That wide impulse pressure. Okay? Not able to maintain perfusion on their own. Headaches, seizures. If we're not able to maintain blood pressure and heart rate ourselves, we're going to have to give medication to help with this, correct? Okay. Initial management of a patient with a traumatic brain injury. So that Glasgow Coma scale is huge here. It really tells us a lot about the patient's status and brain damage. We do a trauma evaluation. Perfusion is everything right here if you look. Okay, we want to maintain optimal perfusion. Are they bleeding? Are they not? This is going to cause a big issue. We want to see where is going on, what's happening, miserably, what is exactly going on. Are we going to need surgery? If so, we're going to the ICU. Okay, we're going to monitor the ICP. That ICP, since we were messing in the brain, is going to be an issue. We're going to have to watch that. And treat for intracranial hypertension. Remember, they're not able to do it on their own anymore for now. Okay. So first brain injury, a closed brain injury. So that's a blunt trauma. Acceleration and deacceleration occurs when the head of the accelerator rapidly decelerates, damage to the brain. There's open, concussion. So these are your basic definitions as I was stating earlier. Understand the difference so you can understand what's going on in your question or with your patient. Okay, an anoxal injury, widespread axon damage, brainstem, head trauma develops immediately. So we're having bleeding. Okay, this is not good, especially if it's a hemorrhage. All right, so here's a concussion. So they can be sent home. Observation is sent home as stated. We're always monitoring level of conscious. They're always trying to make sure somebody's with them. If they do not have these options, they have to stay overnight for observation. If they live far, whatever the case may be. Difficulty awakening. So it's the same thing. You know, that loved one has to be able to check on them every hour, make sure they're arousable. Lethargy, dizziness, difficulty in speaking or movement, severe headache, vomiting. All of these signs and symptoms you need to understand and be aware of so you can identify the problem for your patient. Patients should be aroused and assessed frequently. Okay, so here's some locations of a subdural hematoma. So what does that mean? There's injury, there's bleeding. So remember, the skull doesn't stretch. There is no more room. The brain is not forgiving for any injury. So if we hit our head here and we end up with a hematoma, look what it does to the brain. Look how compressed it is. In the center, look at the subdural hematoma. Again, see the name? A hematoma is a hematoma. It's the location, is what the name says. Okay, so just be aware. Okay, so collection of blood in the space. Patient may have a brief loss of consciousness, return to lucid state, depending on how bad this bleed is. Or this could be sudden, it could be onset, and they can lose complete alertness, movement. It depends on where this injury is at. So the brain is a very unforgiving thing. They could be only temporary until we remove this hematoma, or it could be permanent brain damage. Okay? Hematoma expands, increased ICP will often suddenly reduce the level of consciousness. This is why they have this level of consciousness. It is an emergent situation, as stated. Now, again, in elderly, sometimes if it's a slow bleed, this could be months. But when these symptoms onset, it is an emergency because it's been happening for a while. Usually this area has been not having any, is having an anoxal injury. There hasn't been much perfusion there. So this could be permanent damage. Or this could be onset for a young person, a car accident. Again, this has to be stopped. We have to treat the problems, which is what? Decrease that ICP and remove the reason for the damage, which would be that hematoma. Okay. So treatment includes reduction of ICP, as stated, removal of that clot, and stop that bleeding. So burr holes and a craniotomy, which is discussed in another chapter. Patients will need monitoring and support of vital sign, function, and respiratory support. So remember, if the patient isn't doing it for themselves, we are doing it for them. Pressors, IVs, drips, airway, ET tube, oxygen. So subdural hematoma. Again. The name means where it is, location. So between the dura and the brain. So acute and subacute. So acute is what? Within the 24 to 48 hours you get symptoms. Subacute is 48 hours to 2 weeks. Requires immediate craniotomy and control of ICP because you got to remove the pressure. You got to remove the issue. Chronic develops over weeks to months. Again, the elderly usually are a risk here. Any of us are, but it's usually the elderly. Causative injury may be minor or may have been forgotten. Have you ever banged your head walking into a glass and you just thought that was it, had a headache for a few days? Clinical symptoms, signs and symptoms may fluctuate. Again, it could be that sluggish gait. It could be altered level of conscious. It could be many little different things of the signs and symptoms in the previous slide. So intracerebral, again, substance occurs in the substance of the brain, may be caused by trauma, non-traumatic cause, supportive care, control of ICP again. It's the same care as you keep seeing, okay? Fluids, electrolytes, antihypertensives, if this is an issue. Craniotomy again. So here we go. CT is usually the scan of choice for neuro right away, okay? First, obviously, nothing takes the place of our assessment. X-rays, if needed. CT usually will give us actually where we're bleeding and whatever the case is, okay? MRI and a PET scan as well. Okay, so nursing process, the care of a patient with a brain injury. So that health assessment, have you fallen in the last 6 months? An immediate injury, please focus on these tables. It gives a lot of our nursing process. Baseline, how's the patient onset on arrival? How's the patient when you first get them a report? Baseline is huge. Level of conscious, know that Glasgow Coma Scale, frequent ongoing neuro assessment, and multi-system assessment. As I keep preaching, you have to assess every body system, especially to see if they're compensating, if they're not. Is this affecting their urinary system, their GI system? Again, we are responsible for the patient as a whole. Okay, so patient with brain diagnosis. Here's the main diagnosis. Again, I would study by which kind of patient would have these issues. What would be your interventions if your patient had these priorities? Okay, our biggest priorities here is to decrease that perfusion, right? To get rid of this, find the cause and decrease it. Cerebral edema, impaired oxygenation, risk for post-traumatic seizures. Okay, goals, to reverse everything, right? Remember, more than likely with this huge injury, they're not doing any kind of autoregulation, so they're not controlling temperature, blood pressure, cognitive function. We're looking for that posturing, decorticate, decerebate, sleep deprivation, family issues. All right, so ongoing assessment, especially neuro, the whole body, monitoring those vitals extremely closely for any subtle change. Remember, those subtle changes are huge in an ICU setting, critical care, and any subtle change for a patient with any neuro issues is life imperative, and you could save them time. The sooner we catch something, the less injury and the better outcome. Level of conscious, vital signs, that airway, motor function. strict I's and O's, strict daily weights. Glucose, remember, they can't compensate. We don't know if they're maintaining glucose or not. Measures to promote adequate nutrition, assessment of oxygenation. Are they urinating? Are they not? Do they have any kind of consonant? Are they continent? Are they still intubated? We're doing everything for them. Assessment for constriction causes dressing and casts. So if they have dressings on their head, if they have any kind of, are they clean? Are they dry? Are they intact? Is there copious amounts of fluid? Is there a foul smell coming from it? Is it scheduled to be changed? Is it not? All these subtle details need to be charted. Pad up those side rails for seizures. Seizures, I don't want to say they're common, but unfortunately, it's something that happens too frequently with any kind of neuro condition, and it can cause perfusion issues. It can cause many issues. So we try to prevent them as much as possible with like a Depakote drip and things like that. It just already makes a bad situation worse, is the way I'd put it. Mittens to prevent self-injury and strains. In an ICU critical care environment, these restraints are very common. Why? We're protecting from themselves. That instant need to, the fear of the unknown, scared. They may not even be lucid, but their automatic reflexes to pull that straw they're breathing out of, to pull their lines, to get up, to, they start just tearing at things. They don't know any better, unfortunately. And these restraints are used very commonly to protect them and keep them safe. So why I bring this up? I think in nursing school, and until you really get out there, restraints is the least invasive, it's the last resort. It's a huge amount of charting. They're looked at poorly because it could turn the other way and hurt the patient if they're in it too long. It's constant, the doctor having to reorder and order every 24 hours. Don't get me wrong, these same regulations apply in an ICU setting, but I want you to understand it's looked at differently. It's for their safety so they don't pull their lifelines out. But in a one-to-one case with the nurse, you are in there constantly making sure that they are okay with these restraints. You are charting constantly on it. It's just a different world. So I want you to kind of take that into consideration. So also we need health promotion, right? So, any way to prevent injury, that reduction of stimuli decreases that ICP, decreases stress on the patient, adequate lighting, proper sleep is huge. We all act a little goofy if we're tired, right? We all are not, we have a delay in our reflexes. We stutter, we can't talk. I'm doing it in this presentation right now. Imagine somebody trying to heal. Yes, we're talking about neuro, but just imagine a body trying to heal. The more rest it can get, the better. And if they're not getting adequate rest, it's not going to heal. And they're not going to act appropriate. Skincare is huge. Prevention. I'm glazing over a lot of this because we've been through many of them already. Maintaining body temperature, appropriate level, making sure that they are covered, that they're not left uncovered, that they're not too covered. Sheets, blankets, Tylenol for fever, cooling blankets, cooling baths. If they're diaphoretic and sweating, just wipe them down. You don't want to be sitting in your own sweat. Okay. Support that cognitive function. Reorient as much as possible. You just, it takes a little time, but it'll come second nature after a while. Just that reorienting. Good morning, Mr. So-and-so. Happy Friday to you. Isn't it a great Friday? I can't believe it's October 1st already. Things like that. Every time you come into the room, oh, it's lunchtime. Can you believe this day's been going so fast? Even if they're intubated, it's already 2 p.m. That reorientation of where they are. Remember, you're here in the hospital. Your wife's here now, or she'll be here. Remember, she's coming for dinner today. Just little statements like that could come very naturally. Family support groups, patient support groups. Please remember, a head injury is a lifelong treatment. There is a long recovery ahead. There is no guarantee, depending on the severity, if this patient is going to survive, walk, talk, be able to go to the bathroom on their own, be able to read or write, know who they are, know who their family members are, have full use of their body, have continence, sexual activity. Everything is affected. And I think I said this on a previous lecture for neuro, and I'm going to say it again. Usually The more the patient puts into the recovery, the more they're going to get out of it. However, they go through the stages as well of either the unknown, again, depending on the severity, the anger, the denial, the fear, and usually where their healing process, recovery process is, the PT, OT, movement, neurologic, everything, usually plateaus at 6 months. That doesn't guarantee they're going to stop. That just usually means this is as strong as they're going to get. And there's people that do defy these odds. Okay? So before I start spinal cord injury, I do want to make one statement. You know, everybody is in the acute phase when they come into the hospital, right? That's that onset of the injury. Let's get them through this phase. These patients don't go home. They go now to a rehab center. Rehab for PT, OT, speech, again, to learn all these things again. So this, again, is many years of recovery. So consider not just what that means for the patient, but for the family. Consider their patient's role in their family and how that's going to be changed, how that's going to be altered. Okay, so here's your statistics for spinal cord injury. Main causes is motor vehicle accidents, falls, gunshots, sport-related injuries. Males again. Males are usually the number one here for all of these wonderful things. Average age of injury is 42. Risk factors, young age, male gender, alcohol and drug use. So just that risky lifestyle, primary prevention. It's just, education. Results from a contusion, laceration, compression of spinal cord, primary injury results in initial trauma, secondary. Remember, primary means the actual injury that caused the problem. Secondary is now everything resulting from that initial injury. So major concern for critical care nurses. It's very unknown. We can never say they're never going to walk again, talk again, breathe on their own again. And remember, depending on the location of the injury is going to be the severity of the need of the patient. We've had many come in, we've had a cheerleader fall from the top, fell right on her back, couldn't feel her legs. Of course, what's right away? Is she going to walk? Is she going to talk? Is she going to be okay? We can't say anything. Can't say anything until that swelling comes down around her spine, and let's see how the severity of this injury is. She was lucky. Her swelling came down. She started to feel her legs again. She was okay, a little PT, but we don't know the permanent damage. So we have to say we are not sure. Okay, treatment is needed to prevent partial injury from developing into a more extensive permanent injury. Excuse me. Okay. So spinal and neurogenetic shock. So spinal shock, a sudden depression, reflex activity below the level, muscular flaccidity. So that cheerleader I just gave you the example of, this is it right here. So boom, fell flat on her back. So that shock, right? It just created that immune response to swell around her spinal cord. It was, I think, it was a long time ago, the T area or in her lumbar. Enough that she could not feel her legs, enough that she was voiding on herself sometimes. She could feel a little bit of pressure. It took her almost 2 months and she was able to feel her legs. So shock, okay? But that doesn't mean we just let her lay there, right? It's that range of motion, helping her move, checking her constantly every day to see if there's any sensation that's returned. Okay, neurogenetic shock's different. Caused by a loss of function of the autonomic nervous system. I've been talking about this constantly. So what does that mean? Blood pressure, heart rate, cardiac output decreases because our brain is not controlling the need of the body. Venous pooling occurs because of peripheral vasodilation. So venous pooling occurs because of peripheral vasodilation, right? The body doesn't know what to do anymore. The body doesn't know if we need to constrict and preserve or open and get that perfusion going through the legs, through the arms. Okay, so what does that pooling mean? We're going to have some issues. We're going to have what? That blood pressure issue, the heart rate issue, possibly what? DVTs, clot. There's so many things. Paralyzed portion of the body do not perspire. All right, autonomic dysreflexia. What does that say in bold? Acute emergency. So if this is acute complication, acute emergency, this is an important concept to understand. Any neuro injury can be affected by this. All right, occurs after spinal shock has resolved and many years after injury. This could be something constant. If you suffer from the ramifications constantly of a brain or a spinal cord injury, you can suffer from this. Understand that. So occurs in a person with a spinal cord injury lesion above T6. So I need you Before you, is this going to be on the test? This going to be on the test. I need you to understand something. This is how you need to interpret that. If you are going to care for this patient, don't you need to understand if him or her have a T6 injury or above, what that would look like in a patient, or T6 and below, right? If we have a patient with a C4 injury, what would be her priority right there? Would she have any function or any sensation? No, and she'd have airway issues. She's not breathing on her own. She's going to have a permanent airway. So that means what? Can't move arms, can't do legs, can't breathe on her own, can't feel chest rise and fall. There's no gastric contents moving. There's no bowel movements probably, no sexual function, no sensation in arms and legs, complete total care. Okay? When would they have leg sensation? Maybe when would they be able to have arms, waist down? What would their preferences be? Maybe, not preferences, needs be. Maybe they only need slight support for the sensation of urination, right? Just some bowel training, but there's no leg movement. But they have good control of their arms. So to take care of a patient, you need to know that. So what does that mean? That means I expect you to understand an injury throughout the spine. So I hope that helps there. Autonomic nervous system response exaggerated. Symptoms include severe pounding headache. So anything that is making this patient uncomfortable. So one of the biggest things is a full bladder. A full bladder. Me or you have that sensation to, as nurses, we hold it and hold it, hold it, then I'm dancing to the bathroom. Okay? If they haven't cathed the way they're educated, if a caregiver forgot to cath, if they haven't voided in hours, this is an issue. If they're sitting on a pencil, if we left a syringe cap in the bed and it's laying, or wrinkles in the bed, anything that, right? If we have those sensations, right? We have the sensation that I have a wrinkle on my shirt and it's driving me nuts. I'm sitting on the remote control, things like that. You could feel it though. It's an annoyance. But that annoyance is our nervous system saying, move it, right? If this patient's been sitting too long and hasn't shifted, anything like that, think of you feel burn, you feel pain, you feel, pokes. They don't anymore. And this is the issue. And so symptoms include, so if this is the case, if they're laying on that needle in a wrinkly bed, full bladder, pounding headache, they usually say it's the worst headache of their life. It's a horrible headache that nothing's taking it away. A horrible spike in blood pressure. And I'm talking a crazy number of blood pressure. Stroke numbers. Okay, higher than 200 systolic. Perfused diaphoresis. They can't control it. Nausea, congestion, bradycardia. They just are not doing it, but it's onset. It's quick. Triggering stimuli include distended bladder, distension of contraction of visceral organs, constipation. Again, discomfort, right? If you or I would feel bloated, okay, or stimulation of skin. That's the needle cap under us, the syringe cap. That's a wrinkly bed, things like that. Okay? Too hot, too cold. How do you fix it? You find the problem. You treat the cause. This emergency response is never gonna go away until you fix the bed, empty their bladder, take the stool out of them, things like that. Then all of a sudden you'll see that blood pressure plummet. Now, we could treat the symptoms while we're trying to figure out what's wrong, which is maybe what? Decrease that blood pressure? Doesn't matter though. You're going to give medication. It's going to plummet right back up, right? It's just it's a Band-Aid. So let's give that medication. It's just going to come down slightly. Okay. But then what's going to happen? You still haven't emptied their bladder. Right back up. So nothing is going to solve this until you find the problem. You left 520 blankets on. The caregiver forgot. Take those layers off. Cool them off. You'll start seeing that blood pressure go down. Okay. All right. Rapid assessment to identify eliminating cause. So empty the bladder. Take that poop out. Examine that skin. Make sure everything's flat, straight, clean. Examine any other stimulus, like I said. If they've been in their wheelchair too long and they haven't shifted their hips or anything, it could cause this. Administer ganglionic blocking agents such as hydrolyzed hydrochlorothiazide. Label chart medical record as a risk for autonomic dysreflexia. If they come in, this could be one of those, I've seen some with the medical band bracelets. So right away we know, let's check that bladder, let's check that stool, let's figure this out. Instruct patient to prevent management. So Caregivers need to be, family, whoever's caring for this patient needs to. We've had some younger men who, in their 20s, gunshot wound type of thing, they know they need to empty their bladder at least every 4, and they self-cath, and, you know, they're as independent as they can be. Is it cool? Is it fun? Is it optimal life to stop what you're doing, hanging out with a girl, whatever, to say, excuse me, I got to go cath? No. The younger this person with this injury, you'll see a lot of irresponsibility and neglect in this way, and this can happen, you know, or they just get angry and defiant and tired of having to live their life by a schedule. So it can be this type of situation as well. So you really got to ask those appropriate questions. Okay, so the care of a patient. If it's a respiratory issue or injury on top, we're making sure that airway's okay, you know. I think it's like to L. I don't have it near me. But if it gets to L, you know, you're still going to have respiratory issues. Depending on where the injury is, all these muscles here help us breathe in and breathe out. So even as we go down into the lumbar, you could still have some respiratory loss, you know, that depth of inspiration, expiration, because we've lost control of those muscles. Monitor changes of monitor and sensory. Assess for spinal shock, which is that swelling and compression. You know, we're not going to know severity of injury until that inflammation decreases and we can see if there's sensation that's back. So I keep talking about sensation. So are we checking for sensation? Yes, we are. Are we checking for numbness and tingling? Yes, we are. Monitor for bladder retention, distension, gastric ileus. So what do I mean? We're listening to their bowels. You know, we're checking, we're bladder scanning, we're palpating. Temperature, potential hyperthermia. We're checking temperature rectally if we have to. All right, here's your main diagnoses. Who would have them? These are the priorities. Start thinking of your interventions for all of these for your primary diagnosis. Read your questions when you test to make sure that which one of these is the priority for this selected patient for the day. All right, DBTs, orthostatic, it's just autonomic dysreflexia. It's the rest of the list there. So here's your goals. How are you going to meet these goals for this patient? So ask yourself, who would I see this in? What would be my goals? What would be my intervention? Okay, so I would see this with an injury of C5 or higher, or, you know, motility. I would see this with this spinal cord injury. I would see this with this spinal cord injury. All right, so here we go. Here's the interventions for it. You know, we're constantly monitoring ABGs, fluid and electrolytes. We're making sure that airway's there. That frequent constant suctioning to clear the airway if they don't have that suck-swallow reflex. This patient, more than likely, if they're going to have a permanent airway such as a trach, so a lot of education there. You know, it takes a lot for a patient to adapt to a trach lifelong. You know, they're always feeling short of breath. They're always feeling like they can't catch a deep breath. It's very new and it's very traumatic for people when they first get it. Breathing exercises. So just the slow, calm breathing. They're already constant in panic, you know, because they feel like they can't breathe. Humidification, hydration, assisted coughing. I'm not going to say term cough, deep breathe, but that same concept is always important here. Motility. They can't do it themselves. What are we doing? Range of motion. Spinal cord injuries especially, or anything with brain. Alignment is key. Making sure they're not like this. If we're moving, we're shifting, we're making sure everything is shifting evenly. At least 4 times a day. Neck collar, neck brace if necessary, if needed, to make sure you have that. Okay, so here's a rotobed. This kind of helps with that alignment and that movement. We just kind of wanted you to get an idea of what it looks like. Here's the collar for a minor injury to keep that alignment. Here's a halo system that really looks good that you could possibly be in for 4 to 6 months. Okay, again, it's to maintain after shock or injury to maintain alignment, but they can go home. All right, so strategies to compensate for sensory perceptual. There's many different strategies. Again, they're going to have to learn everything over again. PT and OT are huge here. So what would you take from this? Understand that your responsibility is to care for every portion of the body, every portion of their need, but it is a collaborative effort. So sensory perception, you know, can they feel, can they, you know, sensate? You got to teach them all over again, all textures, buttons, zippers, speech, turning, temporary indwelling catheter. It's the same concept. They may have this for a period of time, but they can't keep it forever. So a lot of education either to the loved ones or to the patient on cathing at home. to alleviate gastric distension. Remember, NG tube is very serious here in this way. High calorie, high protein, high fiber. We want them to heal. We want them to be able to poop regularly, pee regularly, heal properly. Bowel program with stool softeners. Again, if the body can't do it, we have to find appropriate regimen for the patient to do it for them, even when they go home or rehab. Hygiene and skincare related to traction devices. We got to still clean under there. Oh, and that concludes the lecture.